Okay, today I'm going to talk about a project called the California Alliance for Prevention Funding. And this is a new project in California. But before I get into this, I want to give you a little history about why this project started. And here I want to start back in 1910, when Hermes de Fonseca was president. Here are the causes of death in California at that time. So this is 100 years ago. You can see that chronic disease is almost half. We have infectious disease at 30% and other causes. Now, we've done a good job with infectious disease. We have a lot of doctors here, I know. So we have advances in medicine. We've made environmental changes. And this is amazing. Now we have chronic disease at 81% of causes of death in California. Chronic disease is very complex. It's multifactorial. The solutions are complicated. They include behaviors. They include social determinants. They include environmental determinants. And here we have the leading attributable causes of death in the United States. The blue line is 1990. The red line is 2000. I don't know how well you can read this, but tobacco remains the #1 risk factor. But look, poor diet and physical activity is catching up. This is from 2000. We have alcohol consumption next, and I heard that in our presentation this morning, that alcohol consumption is an issue in Brazil, and then other causes here. What this graph doesn't show are the social determinants. So this graph isn't showing poverty and the relationship between poverty and tobacco use. It's not showing education and the relationship between education and poor diet and physical activity. These are the behaviors. Here's some trends among adults in diabetes in the US. And when you look at the map, it's just astounding. So here in 1990, the highest rates are dark blue, and that's a rate of 6 to 8% of adults having diabetes. 5 years later, more states are dark blue, and the light blue ones are turning darker. 6 years later, we have to invent 2 new colors because the rates of diabetes have increased so much. So we have the gold at greater than 10%, and the red at 8 to 10%, and the rest. I wish I had one for 2018, and I don't. But what I can tell you right now is that in California, 55% of adults have either prediabetes or diabetes. So this is California today. Chronic diseases and injuries account for 80% of deaths in California. Nearly 2/3 of adults in California are overweight or obese. 55% of our adult population have prediabetes or diabetes. And expenditures for health care for the top 6 conditions, which are cardiovascular disease, cancer, asthma, arthritis, depression, and diabetes, cost $98 billion in 2010. So I've started with this background because this background is the why for what we're doing. About 3 or 4 years ago, a group of professionals throughout the state of California, and this is professionals from the public sector and the private sector, and the nonprofit sector, got together to develop a strategic plan for the state of California to address chronic disease. One of the #1 priorities that emerged from those meetings was the need for sustained, dedicated funding for chronic disease prevention. Right now, the way it's funded in California is you get a grant for $200,000 and you do a project for 3 years and that money runs out. And then you get another grant for $150,000 and you do a project for a year and a half and that grant runs out. So we're not able to have sustained, constant impact to really address all of the risk factors for chronic disease. And here are the logos for all of the organizations that are involved with this project right now. Some are statewide and national nonprofits, and other are organizations that are collections of public organizations. So this is the mission of the California Alliance for Prevention Funding. And we want to build a culture of health for all Californians, reduce disparities, contain health costs through education and state-level advocacy for new and sustained funding to promote health equity and prevent the leading causes of illness and injury, particularly through upstream prevention. This is how we work. We have dedicated staff. That's me. I am the only staff person to the California Alliance for Prevention Funding. We have coalition operating procedures, and this is something I did when I first started. And I didn't want to spend a whole lot of time talking about procedures for the coalition. It's boring, you don't feel like you're moving forward, but it's very important to establish things like, how do we make decisions? How do we as a group decide when we want to put our logo and support a particular piece of legislation? So we had to get some of those, what we call nuts and bolts, established so that we could work together as a group and that we could trust one another. We developed some foundational principles that we stand behind, and we have subcommittees that do the work. So if you're interested in any more about some of this structure of how we work, I'd be happy to talk to you about that during a break. This is one of our major successes so far. We had a legislative briefing, and we went to our state capitol, and we educated legislators on the need for sustained and expanded support for prevention. And we wanted to show them that it's feasible, that other states have done it, and that there are different ways that it can be approached. There are 3 other states in the United States that have dedicated funding for chronic disease prevention at the state level, and they all do it differently. They have different sources of revenue, they operate differently, they fund similar things. They mostly fund tobacco prevention and obesity prevention work. And we invited representatives from those states to come and talk to the legislature. So this was a low-stress legislative briefing. We weren't asking them to do anything. We wanted to talk about the cost of chronic disease in California and simply show that a state wellness trust can reduce those costs and have an impact on chronic disease. So what's our proposal? We're in the process of developing this right now. And this is, how are we going to do this? I mean, we're going to be talking to people. We want to establish a state wellness fund. We need to have some concrete details. So a state wellness trust, that's another word for the state wellness fund. These are the types of activities that that fund will support. Policy systems and environmental changes, and community programs that work outside of healthcare settings to make California communities more conducive to health and to close gaps in health outcomes and inequities. Here's our proposed revenue sources, and these are the 3 that we've prioritized. We looked at 25 revenue sources, but these are the 3 we've prioritized. One is a soda tax, the next is an alcohol tax, and the next is a tax on high earners. We're considering a soda tax because the spread of soda tax is really phenomenal over the past several years. And here you can see the different countries and cities that have adopted soda tax policies pre-2009 all the way to 2016 and 2017 and 2018. This is a movement that's developed a lot of momentum on the one hand, and on the other hand, the California legislature is really tired of hearing about it. We've been trying to pass it for a few years, and I think there's some fatigue to the messages. And the soda industry in California, like the soda industry everywhere, is very strong. The next consideration is a tax on alcohol. And some things about that. The state of California has among the lowest alcohol taxes in the USA. Each state has different taxes. The alcohol tax in California hasn't been raised in 27 years, and it was recently cut. A 3% tax on all alcohol would raise $850 million a year. And also, between 62 and 73% of California voters support increasing the tax. So that's a good possibility. There's 3 types of alcohol you could tax. You could tax beer, or wine, or spirits, like gin and vodka. The wine industry is very big in California. I think that would be impossible. But we could just tax beer, and so we're looking at various ways to tax alcohol and what might be more successful. The last choice we prioritize is a tax on the wealthy. California's high earner income tax is the highest in the country at 13.3%. Many wealthy Californians will see a tax increase in 2018 due to new federal tax laws, and others will see their taxes decrease. In addition, there were new higher taxes on the wealthy that were extended in 2016, so I'm not sure that this is going to be our most strategic choice. I think the soda tax or the alcohol tax will be. Here's some other things that we considered but we didn't choose. A fee on health insurers, tobacco, legal settlement funds, and fees on medical providers. So I've just talked about the purpose of the funds, what the revenue source of the funds would be, and we're going to need to have a governance structure. Because the revenue sources that we're considering are taxes, the structure needs to be a public agency. And so we want to have a commission that sits within the state but has spending authority, so that a group of people who are not elected officials are making decisions about how that money is allocated. And so members would be appointed by elected officials, and we would have various descriptions of appointments. So we need a medical doctor, we need a public health professional, we need someone who has experience in tobacco, we need someone who has experience in community mobilization, various seats that people could sit on. And there'd need to be an administrative entity to manage the work. And here's how we propose to allocate the funds in the trust. The State Department of Health would get 10%. Typically, the State Department of Health does a really good job on mass media campaigns throughout the state. They've also done a great job at providing technical assistance to some health departments and to some nonprofits who don't have as much experience with primary prevention strategies with systems change. County health departments would get 45% of the funding, and that would be a allocation they would get every year. They would need to submit a work plan, but they would be guaranteed funding every year so that they could build on and sustain programs to address chronic disease, because we know that that's a long-term effort. We're not going to reduce rates of tobacco. We're not going to fix the influence of poor education on diet and health overnight. So this is some place where we feel like we need sustained funding. 35% would be for competitive grants to county level, regional level, and statewide nonprofits. And then the administrative entity that's managing the fund would get up to 10%. So here's our next steps. We've got our proposal. We're going to be holding regional convenings to mobilize partners throughout California. So we'll bring our proposal around. I'm not specifically asking for input, but we'll get input, and we'll incorporate that. We also know that the political environment's going to change, so though we have a proposal, we know it's going to change. We're going to have to change it depending on who the new governor is, what other political considerations will be. So we go out with the proposal and we're willing to change it, and part of that change will be feedback we get from partners. We need to attract non-traditional partners, and that's what you really need to make a movement to do something as big as passing a new tax in California. So some examples are teachers, parents, farmers who, I mean, the agricultural industry is huge in California, and if farmers have more of an opportunity to sell their crops locally, we'd like to bring them on board. Sports celebrities, youth groups, private sector, and others. The legislature is a little tired of hearing people like me talk about public health, because they hear people like me talking about public health all the time. So I need to be there, and we have our data, and we have our credibility, but we need a much more diverse group of people around us in order to make this visible and to make it work. We're going to hold a second legislative briefing, and we're going to present our proposal. And this is a big step. We're going to work with a legislator to write a bill. These are 4 bullet points that will definitely take more than 2 years. We know it's an ambitious project. Is passing a new tax in California ambitious? Yes. But this is one of my favorite quotes. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Thank you.
It's kind of a earmarking, is kind of a specific tax that will be fund health initiatives?
Yes. So we want to write the law very carefully. We want to build what we call a firewall in our new law for the tax, so that those funds are specifically for chronic disease prevention, and that if there's a bad year in the state budget, they can't be taken to replace highways, that they will always be for chronic disease prevention.
É interessante que aqui no Brasil acho que é a CID, né? Que nem tem a CID combustível, a gente está discutindo CID tabaco e a ideia que ela está trazendo é uma CID DCNTs. É interessante.
No, taxpayers do not like to pay more taxes.
And you are in the government that is reducing taxes.
Yep.
Now it's an official policy.
Yep.
Yes. So how can we do it?
Well, the way we can do it, we think, is that there's one of the things I didn't talk about here, because it's a whole other topic, is that we're looking at return on investment. And we're looking at, if you invest $10 in chronic disease, how much savings will there be in healthcare costs? So can you actually make money or save money by having an initial investment in chronic disease prevention? So that will be one of our arguments. But really, I think the argument is, the strategy is going to have to be is mobilizing partners and mobilizing that wide array of traditional partners. We saw 55% of people in California have prediabetes or diabetes. Everyone knows, everyone has a family member who probably has diabetes. So I think that when we go out with data and we present it in a familiar, in a non-scientific way, that we can really mobilize groups to lean on their legislator to pass a new tax. But by no means do I think this is going to be easy. That's why I ended with that quote.
Eu queria fazer uma pergunta, mas não para ela, mas do assunto dela para nós. Que tipo de mudanças ou de legislação, ou que tipo de mudança em termos de taxa ou de contribuições que a gente pode fazer em termos municipais? Existe alguma autonomia para isso? Porque se a gente for pensar em mexer com receita federal, dinheiro federal, está tão longe da gente. Eu acho que é tão difícil até sensibilizar as pessoas para isso, né? Quem que quer que aumenta qualquer tipo de taxa, se vai ir para Lava Jato, se vai ir para... que é o que a gente pensa hoje, né? No Brasil, mexer com isso, tem que estar perto, né? Tem que estar perto das pessoas. Isso tem que vir de perto das pessoas. Se alguém tiver alguma coisa que puder falar, porque eu não tenho a menor ideia, só tenho a dúvida disso. Bom, Adélia, eu acho que, na minha opinião, a gente tem que atuar em todas as frentes possíveis. Então, acho que quem tem mais possibilidade de atuar no município deve atuar no município. Quem tiver possibilidade de atuar no Estado, atua no Estado. Não sei dizer do município. No Estado tem ICMS, por exemplo, sobre produtos de tabaco, de álcool, que pode ser levado.
Porém, quem tem possibilidade de atuar também em nível federal tem que se fazer presente. Não é tão difícil assim marcar reunião na Receita Federal, não é tão difícil assim conversar com o legislador. A gente tende a sentir que isso é inacessível para nós. Mas a CT, por exemplo, é uma organização que investe muito em advocacy, estimula muito as ONGs, e quem puder se fazer presente lá, porque as empresas estão todas lá, todos os dias. Então, os interesses, na verdade, que a gente pode ter em termos de elevar a taxação de produtos não saudáveis, por exemplo, que é um mecanismo considerado inovador para financiar a Agenda 2030, para financiar também, junto ao que foi discutido hoje, né? Foi falado, por exemplo, da parceria público-privada, etc., mas tem outros mecanismos que podem ajudar a financiar, e a taxação de produtos não saudáveis é um deles, que a população em geral apoia e que pode ser discutida também num âmbito maior, como o âmbito nacional ou federal. Então, a gente, por exemplo, acompanha, tem a proposta do CID refrigerante, CID tabaco, que são já propostas legislativas que estão tramitando na Câmara, e acho que quem puder também acompanhar, vale a pena. Então, eu sempre defendo que eu acho que a gente não precisa escolher uma frente, acho que a gente pode ir em todas elas e aonde tiver chance.
Muito obrigada. Bem, eu acho que eu observo que, para a gente falar de novas taxas num país com tantos impostos quanto o nosso, é justo se a gente falar de produtos não saudáveis. Mas a gente pode pensar em transferência de taxas. Então, nós tivemos agora, recentemente, a aprovação de transferência de parte das multas de trânsito, 30%, se não me engano, transferidas para os órgãos de saúde, para o Ministério, para a Secretaria Estadual. A gente pode pensar neste sentido, por exemplo, de como o maior número de acidentes de trânsito é com motocicleta, transferência de parte do emplacamento ou, sei lá, uma outra taxa referente à motocicleta ser transferido para os órgãos de saúde. A gente pode pensar na direção de transferência de taxa, mas não de novas taxas, sobre taxa, exatamente.
We thought of that. So that's a good idea. The challenge with that is we are taking money from another state program. So we're taking money from schools to pay for chronic disease. We're taking money from building bridges for chronic disease. And so we thought that taking money from another program might be harder than getting new money. In addition, when we get new money, it's going to be ours. And no one's going to be able to take it away. However, I agree with you that in many ways, using existing money is easier, but taking money away from an existing program can be really hard, because then you develop whole new enemies within the government. So that was our challenge, but we very much considered that.